some of the trends, because we are finally starting to see the dollar amounts and the number of claims really start to subside now that we've had Medicaid expansion in place for a full year. So, Kelly?
For those of you that are new, you see there are a few new faces to me. I'm Kelly Brassfield, policy analyst, and I also work with the CAP program, kind of the interim coordinator program. Took over what Catherine gave me after she retired. Carolyn and I kind of split her duties up, and so I worked with the budget side for the CAP program, and Carolyn still maintains the case management. And so I'm going to start off with some trends. I went through the county reports that you all submit every year and just kind of took a look at the case numbers to start off with. So what you can see here is the blue line is the total cases that we've had since 2015. The cases started to rise pretty steady. And then in 2017, when the individual mandate was repealed, we saw a nice spike. About 600 cases that year, pretty evenly split between the state and the county level. The bottom line is the CAP program, the middle gray line is the county, and then the top is the In 2018, we saw the peak, and then at that point, we had Medicaid expansion that was implemented, and our cases started to come down. And then, as it continues, you can see that at the CAT level, we have those case numbers currently, what we've had so far for this fiscal year. I don't have your reports because the end of the year is not up yet. As soon as I have that, I'll be able to add that in. But you can see in the very bottom corner, there's 368 CAT cases. Now that includes the meeting that's coming up. We see that drop even more. We're going to talk about mental health here pretty soon, but between 20 and 21, we received the IMD waiver. For those of you that are not familiar with the IMD waiver, it allows for the IMD stands for Institution of Mental Disease. Did I get that right, Catherine?
Carolyn?
Catherine's here. At any rate, it allows for those facilities to bill Medicaid for individuals with co-occurring disorders. And they are able to stay in these facilities for up to 30 days. Before, we weren't able to bill Medicaid for these individuals, and this is why our behavioral health costs were so high. With this being implemented, the idea is that they will continue to apply for Medicaid for these individuals, and our costs will continue to go down, as well as the implementation of House Bill 316, which Seth will go through here shortly for those of you that weren't able to make it to our spring trainings. So, let's look at the mental health costs. Again, the top are the cases. The top is our total cases. And just the mental health cases, the middle, that's the orange line. It has continued to rise. And then our non-mental health have continued to go down. We are just seeing more cases overall in behavioral health. And our non-behavioral health are continuing to go down. See, the mental health cases have been on upward trend and accounted for $8.5 million in 2018, $8.9 million in 19, and just over $10 million in 2020. So let's take a look at the payments trend. The total amount paid was on a decrease. Again, in 17, we had the repeal of the mandate. We saw a spike where we topped out at over $40 million. We continue to come down. You can see the state is all over the place and county is pretty steady. So far for 2021, we paid out $10.9 million. Now we still have one meeting to go, and we also have cases that are continuing to trickle in. Let's kind of compare the payments to the case line. The yellow line added to the payments is that total number of cases that I had shown you on the previous slides. We're seeing a steady decrease, and hopefully we'll see that bigger decrease over as a whole as we continue to enroll these individuals in Medicaid and that IMD waiver is being utilized. However, you'll see that our payments are going up again. So let's look at the history. Cases go down, but our payments are going up. The overall cost per case is on a rise. This is due to the extended hospitalization in certain cases. They're extensive and they're expensive, as well as the increased cost of healthcare overall. So we have 314 on this slide. You saw 368 before. 314 is what the CAT has actually approved through April 6th. The 368 includes the pending cases for the next meeting, which happens in a week or so. Any question on trends so far? All right. I'm going to turn it over to Seth.
So really what we're looking at, I'm going to go back just a few, and this is one of the driving factors for the legislature to do what it did with House Bill 316. We're seeing costs go down. Now, as Kelly mentioned, it's just under, just under $11 million so far from 2021. That amount's going to come up, but it's still a significant reduction from where we previously were. And again, a lot of that is because more and more people are being enrolled in Medicaid. And so this really sets it up for the conversations that we had this legislative session about what is the future of the Indigent program. And the legislators that reached out to us and really drove this issue wanted to make it clear in statute that everyone has skin in the game, so to speak. There's personal responsibility here. And if everyone in Idaho essentially can either enroll in Medicaid or can buy insurance, and if you're buying insurance through the exchange, then there are subsidies involved to make it more affordable. Why in the world is the state of Idaho and counties, your taxpayers, why are they picking up these medical expenses? And as Kelly showed, the cost per claim is going up significantly. Those are large increases. Year over year, that's a little over $7 million increase per case. And so the legislature wanted to make a policy statement position that, look, you have a responsibility as a resident of Idaho to either go out and enroll for Medicaid or procure private insurance. And if you don't do that, then you're responsible for these expenses. They essentially want to get government out of the business of paying for medical expenses when you have other resources at your disposition. And that's what brings us to House Bill 316. And I'm going to talk with you about this. Some of you have heard some of these comments that I'll have, but for others, you missed them. Kind of the backstory with House Bill 316. The sponsor of the bill was Representative John Vanderwater. He's from District 22, which is in Ada County. And he's been interested, and in fact, if he had his way, he would have repealed Chapter 35 of Title 31, which is the medical indigent statute altogether, just basically into the program in one fell swoop. The other legislator that was very involved in this was Representative Fred Wood, who chairs the House Health and Welfare Committee. He is a retired physician, and he had concern of just repealing the program when there's some level of uncertainty out there. That uncertainty rests with the U.S. Supreme Court. In this month, in fact, we're expecting a decision from the Supreme Court on whether or not the Affordable Care Act itself is constitutional or not. It's been challenged, and it's to the Supreme Court. Depending on what that decision is, it will, again, impact what happens with these indigent services. And so he was reluctant to just repeal the program until there was certainty from the Supreme Court as to what the future will hold. So I fully expect over the next couple of years, depending on the outcome of the Supreme Court, if they uphold the Affordable Care Act, we will likely see a repeal of Chapter 35. That's the medical side. None of this, to be clear, impacts Chapter 34, which is the non-medical side, indigent burials, rental assistance, those types of things. We're only talking about medical care. And you know, we were put under the microscope, put under the gun, so to speak, early in the session. The governor, day one, state of the state address said, I want $12 million from counties. And the goal at that point in time, or where they wanted that money to come from, that $12 million, was out of county revenue sharing from the state. And you know, we talked with our legislative committee, we talked with many of the counties around the state, and no one wanted to forego revenue share. That's a growing pot of money. It's increasing significantly year over year. In fact, this year we saw increases of between 12 and 13% year over year. So it would be a growing percentage that you would be missing out on in general fund revenues. So the alternative that was presented in talking with Chairman Wood and Representative Vanderwoude was, okay, you guys don't want to lose your revenue sharing. You're going to have to take on more of a responsibility for public health districts. And in most counties, this will be a net positive. If you're in Eastern Idaho, it's a little more nuanced than that. There are a lot of counties in Eastern Idaho that have very little indigent medical expenses. And for those counties in Eastern Idaho that have lower per capita, so to speak, indigent expenses, there likely will be a cost increase associated with House Bill 316. And we'll talk a little bit about that. There are two counties up north that kind of fall in that position. You know, Cooney County and I think Bonner County are in a similar position to counties in Eastern Idaho. So what does House Bill 316 do? Again, the most important part of this bill, House Bill 316, is again this policy that has been set by the legislature. And Kelly's going to talk a little bit later about really what this means for the indigent program. But in essence, the policy is, if you qualify for Medicaid, either you enroll, or when you have a catastrophic health event, the hospital is going to enroll you. The county should not pay for your medical expenses, and the state should not pay for those medical expenses. And that's important point number one. Important point number two, if you don't qualify for Medicaid, you have access to insurance, either through your employer, or if your employer doesn't provide insurance, you have access through Your Health Idaho. And most people who get insurance off Your Health Idaho, they get a subsidy so that insurance is affordable. And so that's the second important point. If an individual is eligible, this is eligible for insurance. This isn't, can I afford the insurance or not? This is eligibility. If an individual is eligible for insurance, they're no longer eligible for the county insurance program beginning March 1st of 2022. That's an important note. And so, again, it doesn't matter if I can afford that insurance, it's whether or not I'm eligible to buy that insurance. And then the third piece relates to involuntary commitments, the mental health. Again, any individual that either qualifies for Medicaid or insurance is ineligible for assistance from the county for those involuntary commitments. Now, this is going to get a little messy. Kelly's going to talk about a little working group that we're participating in right now to try to clarify what happens if an individual doesn't qualify for Medicaid and doesn't have insurance. Who pays if the county isn't going to pay? Is the state going to pick up the tab? Is it the provider that's going to pay for the tab? So we'll discuss that here in a moment. But this is the core tenet of House Bill 316. That, again, is an Idahoan, you have responsibility to go out and make sure that you have health coverage either through Medicaid or through insurance. And it should not be the county's responsibility to cover your expenses if you don't do that. Wayne? Inmates. So jail medical is still the responsibility of the county, right? That is clearly a county responsibility. As we've been trying to figure out, okay, where's the gap going to be? Because there still might be claims that come to you that are legit. One of those areas may be with undocumented, right? If you've got undocumented, there are some instances where there might be some federal coverage for them, but if there's not coverage, you might have to keep a shelter program in place for undocumented, right? And there might be other loopholes that we come across that we find as we move forward with this, but there really should be a very, very, very small group in your counties that are going to fall under the program. Joe?
What does that mean in terms of which would have been in the former program catastrophic cases that would exceed the deductible county pays, but we may bear liability existing cases after the program is done away with around there?
So, as far as, what happens if you got an individual who doesn't have insurance and doesn't qualify for Medicaid, they've got a $350,000 claim. Well, if they qualify, if they're ineligible for insurance for whatever reason, and they qualify for assistance, the $11,000 cap is still in place to protect the county. The cap program is still in place to cover the expenses above $11,000. So that's in place. Now, if an individual could have bought insurance, subsidized on the exchange or through the private market, non-subsidized, and they chose not to, then it ultimately is between the individual and the medical provider to determine how those expenses will be covered. But if you've got somebody that would fit in one of these categories, you've got an undocumented, has an emergent expense, in that case, you're only liable for the first $11,000.
Well, in the event that the catastrophic program completely gone in the future, that would still hold true with the
So in the future, the question is, what happens if the state cap program goes away with the counties? They're wedded together. If you eliminate the cap program, put it to bed, you've got to wipe out the county program as well.
So it's still, it would then be part of the Medicaid expansion program that they'll have to divide their plan on the exchange or working it out directly with the medical provider.
Correct. And there will continue, you might have cases in suspension. I think Kelly's going to get a little bit of this. Like what's the future? If you've got cases in suspension, you'll still process those through even after the March deadline. You'll have applications come in, potentially after March for services that were rendered prior to that March deadline. So you're still going to have a trickling out, a phase out, but in all likelihood, by the end of 2022, really everything is likely going to be off the books. So the other impact area is on involuntary commitments. And as Kelly mentioned, I'm going to bounce back to some of these slides. Where's the one on the expense? Maybe it's not there. I'll use this one. So the big thing that stands out as we look at the data over the last few years is how much we're seeing increases for mental health related services, in particular involuntary commitments. We're at the point now where over 50% is statewide. When you aggregate all of your expenses, about 50% of the dollars you're paying out are for mental health and voluntary commitments. That's how bad this mental health crisis has become statewide. That's where most of your expenses are. And this is where there is there's work to be done here. The legislature, the reason why they have an odd implementation date of March 1st, it doesn't align with the state year and it doesn't align with the county year. It's just kind of out there. The reason for that is so that we can work through these issues between now and when the legislature reconvenes in January, have a piece of legislation ready to go. So that legislation can be introduced and run right at the beginning of the session. That'll become law before March 1 triggers and all of this potentially goes away. And this is, again, Kelly's going to talk a little more about this, but moving forward, after March 1st, the county should have minimal responsibility for involuntary commitments. And that should help save counties, especially some of the larger counties. Ada County, Canyon County, these are huge expenses for you guys, big expenses. And so this really should provide cost savings for you as you're going into this next budget year and future budget years. But we're trying to kind of sort through really what happens in the future, because it's a little different if you are, we've got, Treasure Valley is really where these IMDs are. There's Intermountain Hospital, and then there's Cottonwood Creek. And they're facilities that are set up specifically for mental health services. And they're not like a traditional hospital. Far, far different. And so what happens in the event that you've got an individual that refuses to enroll in Medicaid? Right now, under Idaho law, that IMD cannot enroll them in Medicaid like a hospital can enroll one of its patients in Medicaid. So that's one of the things that's being explored is can these IMDs automatically enroll someone coming into their facility for Medicaid, pay the expenses, even though that individual isn't necessarily in a state of mind where they they can do that. Health and Welfare, Department of Health and Welfare estimates that 93%, I think that's the right number, Kelly, 93% of those individuals that go through the commitment proceedings would qualify for Medicaid expansion, right? So there is a funding pool for 93% of these individuals. What about that 7% that doesn't qualify for Medicaid and doesn't have insurance? Like how do you receive payment for those services if the county isn't covering that expense, right? In all likelihood, we think this is probably going to end up with the state of Idaho, but that's unclear. Now, just because the expenses associated with involuntary commitment process are going away, that doesn't mean that all of your involuntary related expenses are going to go away. Counties will likely still have a responsibility for transport, right, through your sheriff's office. That expense isn't going away. The designated examiner, DE. Right now, there are 2 DEs. State pays for one, county pays for the other. The discussion right now is, you really don't need 2 DEs. You can do it with one. If that's the case, then potentially the state takes it on, but that might also remain with the county. But the big expenses, the medical, psychiatric, and hospitalization expenses associated with involuntary commitments will go away from the county, from your responsibility. And again, that will provide a significant savings to your taxpayers. Any questions on, before we get to the other big part of this bill, on involuntary commitments? Tanya?
Will you repeat her question?
So I will. So the question from Tanya is, if an individual doesn't qualify for Medicaid and doesn't sign up for health insurance, who pays that mental health bill, right? And that's what we're going to sort through over the summer. We hope the direction that we go in here is that it ends up being the state that picks it up. Now, by statute, with this change, counties don't have that responsibility. But there's a working group, and some of the legislators, just so you know, that are involved in this conversation are Fred Wood from your neck of the wood, John Bounderwadi from Ada County. We've got Senator Riggs involved in the discussions from up here in Kootenai County. Senator Lee from Payette County is involved in the discussions, and Fred Martin from Ada County. Those are the legislators that are talking with us, as well as the Hospital Association, who's involved, and the Administrative Office of the Courts are involved in these discussions. And so I anticipate that by the time we have our conference in September, we'll have a draft of what the next bill is going to look like, and at the end of the day, what the responsibility of the county will be, what the responsibility of the state will be. Joe?
There's still quite a significant pushback from the Hospital Association on what liability they will bear.
Yeah, it's interesting. So the question was, has there been a lot of pushback from the hospitals with these changes? There was significant pushback in the legislature, but again, the legislature had a position that they wanted to affirm. And so, the hospitals were really not able to influence the outcome. They've kind of they've ceded ground with traditional medical care, hospital care, right? They will readily acknowledge that once Medicaid expansion happened, they knew that they were on the clock, and at some point those hospital expenses would go away. So they're not pushing back so much on those expenses. Where they're pushing back a little bit is on the involuntary commitments. It's primarily coming, it's not coming from the traditional hospitals. It's coming from those IMDs that specialize in those services. Now, this is a game of carrots and sticks, right? We were at the legislature. So, the carrot that was dangled out there is that, you're not going to lose your revenue sharing if you go along with this, which no one wanted, but the stick is you're going to have to come up with funding for something else, and that's public health districts. That's where the stick comes in. And again, this does not line up with anybody's budget dates. We raised this issue. In fact, there were some that wanted to delay. Our recommendation was to trigger this October 1 of this year, of 2021, so it aligns with the county budget year. That gives you guys time to prep your budgets and then trigger it October 1. The hospitals felt like October 1 was too early. That if we went October 1, that they just wouldn't have time to plan for this. The hospitals proposed July 1 of 2022. The legislative response to that was, well, if it's July 1 of 2022, why the heck are we doing anything this session? We can just come back and do it next year. But the House wanted to get something on the books, and really we kind of negotiated and settled in the middle at March 1st of 2022 for all of this to trigger. So it's going to require some gymnastics, some budgeting gymnastics for the clerks and putting together these tentative budgets. Because again, for the first, really for the first 7 months of the state fiscal year, and again for the county, that's the first 5 months of your fiscal year, the county does not have responsibility, it's all in the state. But then beginning March 1st, that's when the county starts picking up the tab. So you're going to have to kind of account for that in how you budget this year. Now, there's a floor that's established in statute. And with that floor, the county contribution, now there are two contributions in essence that the counties are going to provide. There's the county assessment that you're already paying for. There's nothing in this bill that provides direction as to what that amount should be, or whether or not a county even pays that amount, right? And we've had a county or two over the last year explore ways to not pay that county assessment. This bill doesn't impact that whatsoever. What this bill does impact is the other payment that comes from the state that the county will now be paying for. And what the bill does, because the legislature did not want to harm health districts, they put in there a floor of 2021. So whatever the state was paying, and it was just under $10 million in 2021, is what will be paid by counties into the future. That's the minimum. And it is up to the counties to decide whether they increase it from that floor or not. And that will be decided county by county. How will that decision be made? Each public health district has a budget committee. By statute, the budget committee is comprised of the chairman of the board of each county commission within the health district. Now, there was some concern with that because sometimes that budget function, the days that you're working on that falls on the day that the chairman of the board can't be there, so the county isn't represented. This legislation allows the chairman of the board to designate an alternate. So, are you chair? Not no, Jack's chair. Okay, so Jack, by statute, should be the Twin Falls rep on the health district budget committee. This is different than the health district trustee. If Jack can't make that meeting, then he can designate either Don or Brent to represent him in that capacity. That's new. You used to not be able to do that. But it's that budget committee within each health district who has responsibility to determine how each district will portion out those dollars. Now, if that budget committee can't decide on how those dollars are going to be apportioned out, then it falls to the default, which is 70% based on population, 30% based on market value for the county. Now, there are some other changes related to health districts that we're not going to go into because it's more administrative. But at the end of the day, what this means for counties is that the Board of County Commissioners within each county has a lot more control budgetarily over what health districts do than what they had prior to this bill. Prior to this bill, salary decisions, the county had no say in those decisions. That all was directed from the governor's office. Now that's on the county's plate, so you guys have the ability to determine at a regional level what wages are going to look like. You're not tied to the state anymore for that. So if you're in an area where you feel like the state has been underpaying those health district employees, you've got the ability to move those folks up. If you feel like the state was overpaying for those employees, you've got the flexibility and control now to control that, right? And so that's something that the counties didn't have. So you couple this with another bill that we're really not talking about today. That bill was Senate Bill 1060. Senate Bill 1060 requires the Board of County Commissioners to approve a public health order in order for it to be effective. So you now have authority over countywide public health orders that you didn't have before, and you now have budget authority over health districts that you did not have before. So it really puts the commissioners in more of a driver's seat now as it relates to public health. And that was one of the things going into the legislative session. There were a lot of concerns as to really, was there adequate oversight of health districts? And between this bill, House Bill 316 and House Bill 1060, the legislature really put counties in the driver's seat as it relates to public health districts. So whether that's something that you hoped for or not, you now have the keys. So, Kirk.
So I've got a question on the health districts, and if the counties are kind of, has a say in what they do, what if they decide to not fund them at all?
So, from a county perspective, this minimum amount, this 2021 amount from the state on the state share, you have to fund them at least at that level, right? So there's not a lot of leeway there. But as far as the county portion, the other county portion, you've got some flexibility. Now, there are services that need to be provided by statute, right? And if you don't fund those services, you're going to run into a problem. It's likely going to go to the court. The court might direct you to do certain things. But if through the budget process, and I don't, is Nate the chair in your county? So Nate will serve on the budget committee that will, help to make these budget decisions for the health district. If there's a sentiment that, the health district is doing too much or too little in a certain area, that budget committee has some flexibility to shape what happens. Now, the reality is when you're talking about revenues to the health districts, 70% of those revenues come from non-county sources, right? They come from contracts that the health districts have with the Department of Health and Welfare or DEQ. They come from food inspection fees and things like that. So most of the funding for health districts comes from other sources. And I believe that this is kind of going to be the next evolution of this discussion. Right now, the fees that are charged by health districts are set by rule, administrative rule. And if the state is now out of the game, why does the state get draft rules for the health districts? Why can't the counties do that? And so, I believe that's something that counties are, right to explore. When you're talking about funding of health districts, can it be more user fee supported as opposed to property tax supported? I think those conversations are appropriate to have in that set. Vicki? That will require a legislative change, right? Right now, there's not a framework or a mechanism for a county to withdraw from a health district or for a county to create a county health department. For that to happen, it would require the legislature to authorize a county to contract for services or hire their own. Now, it's not to say that that couldn't happen, but it would require the legislature making a change for you to do that in Adams County. Again, so this afternoon, we're going to talk a little bit about, in the business meeting, about legislative ideas and proposals for this next year, right? And, that's something that's worth bringing up. I don't know what the flavor is of the full group for that, but it would require legislative change for that to The question was, and we hear this, it's kind of twofold, right? Vicki's perspective is from a small remote county compared to where the district is headquartered. She's in Adams County, and the health district is housed in Canyon County, right? And her argument is that, look, my county doesn't really utilize the services of Central District Health, but for a few things that the county is capable of contracting out for. So why do we have to be a part of this county where we've got one vote out of the 6 counties in that district? The flip side of that, and you hear this from larger counties sometimes, is why are we subsidizing the smaller counties, right? And so really the question is, and it's likely something that's going to be debated for the next few years, given everything that we've been through. What is the appropriate governance oversight and service delivery model for public health districts? Is it a county-based system or is it a regional-based system? And again, because I've heard from not just Adams County, I've heard from several counties, big and small counties, like really, what is the appropriate model and how do we ensure at the county level that we have sufficient say and oversight into the services that are provided? And if there aren't services being provided in my county, what's my recourse? I mean, that's. But again, structurally, to make these changes, it would require the legislature making these changes. So, any other questions on health districts? So we've talked about this. Really don't need to talk about Medicaid expansion. So I'm going to, as we're talking about, we're going to transition to really the future of the Indigent program right now, unless you've got questions related to the county Indigent program or public health district. So any lingering questions before we start talking about really what's to come with these programs? Yeah, go ahead, Ryan. Correct. Yeah. So let's take your Central District Health. If Central District Health has reason in their view to institute a mask mandate in Ada County, for example, like they did during this last fall, winter time period, you now have the ability as a board of county commissioners to come together and say, we don't agree with the recommendation of the health district. We are going to essentially rescind the order. You have the ability now. It has to be for a county-wide order. So if you have Central District Health, let's say they quarantine someone who has tuberculosis, and that individual doesn't want to be quarantined, they can't come to you as a board of county commissioners and say, hey, resend this order from the health district that quarantines me. It has to be a county-wide order that affects everybody who lives in the county. Likewise, let's say Central District Health said, look, we're going to do a district-wide mandate, and all 4 of the counties in, well, there are 5 counties, excuse me, in Central District Health. There are only 4? Okay. The 4 counties in Central District Health, they're under this mandate. In that situation, each county board within Central District Health would make that determination. And it may be that, Valley County says, we feel like it's an appropriate action. We're going to uphold the mask mandate in Valley County. And then Boise and Ada County say, look, we don't need a mask mandate in our counties. We want to do something. You have that authority now that you didn't have prior to the legislative session. Mark? Yeah, really good question. Counties, you don't have full authority, right? Cities within Idaho code, mayors have the ability to issue public health orders. And a mayor can issue a mask mandate within their city. This happened in a number of places, but if you look at within Ada County where I live, City of Boise had a mask mandate in addition to the mandate that was issued by Central District Health. Central District Health lifted their mandate long before Boise lifted their mask mandate. And because Boise has jurisdiction within the city of Boise, that mask mandate stands. The same is true of a school board. If the school board chooses to require students to be masked within the school, they have the authority to do that, independent of the health district or independent of the county or the city. Can you?
Kelly, I think Dawn had a question.
Seth, could you remind me, did they rescind the ability for cities to go outside their borders?
Yeah, so cities never had the ability. The statute was in conflict with case law. So there was there's longstanding case law that states that a jurisdiction only has authority within their corporate boundaries, right? And Boise was another good example. Within the statute reads, well, it did read until the legislature passed the legislation, that a city's order could extend 5 miles outside the corporate boundaries. And that becomes a real problem when you're in an urbanized area like in Ada County, where you go 5 miles outside of Boise and you're in Cuna and you're in Meridian and you're in all of our cities probably within that 5 mile radius, and then you're in Eagle. And so, there was some debate over, what authorities were there. The legislature put it to rest. If the city does do a mask order, that mask order is only enforceable within city limits. It can't be enforced outside of city limits. And it wasn't just Boise that did this. There were a few other pockets around the state where cities wanted to enforce 5 miles outside of the boundaries. Did I see another hand? Okay. Well, I'm going to shift gears a little bit and talk about ARPA and potentially the role of ARPA moving forward. Now, this isn't intended in being a full-on ARPA presentation. Tomorrow, we have Jonathan Sheffield from the National Association of Counties who's going to join us. Jonathan's going to provide a lot of detail and context from the federal discussions that NACO's been involved in as to what to expect with ARPA. And then just as an aside, one of the things, our board, IAC's board, is going to be Thursday, Friday of this week, and we have from staff, a recommendation we're taking to the board to contract with Ide Bailey to help us with guidance. I've got a quote from Ide Bailey, everything's ready to go, and so we'll be having a conversation with the board. And what our recommendation is that the board authorize IAC to contract with Ide Bailey, take the federal guidance, and really add some flesh to the skeleton. We're getting a lot of questions related to buildings. We're getting questions related to, you name it, of how funds can be used. And so we want to have a resource for you, and we'll be working to do that. I do want to have a caveat here, though, that anything that we push out there, before you do anything on it, you'll want to consult with your own legal counsel to make sure that they're in line with what's being recommended. Because we're not legal counsel. We're trying to provide assistance and help, but at the end of the day, your prosecutor is your attorney. But there are some potential allowances for these ARPA dollars to be used for public health and welfare-related services. And we want to talk a little bit about that because for some of you, that's going to help serve as a bridge as we transition to this new model. It also is going to have an impact on involuntary commitments, providing funding opportunities. So when we talk about behavioral health services, ARPA itself, I guess for those of you that don't know yet, you've been living under a rock, ARPA stands for the American Rescue Plan Act. That's the latest round of federal funds. It's basically this year's version of the CARES Act that came last year. And there are some specifically allowed uses that fall under the social services umbrella at the county level. And the big one is for behavioral health services. There's pretty broad allowance for ARPA funds to be used for mental health related services. And so kind of like the presumption is that the mental health issues that people are having right now stems from COVID and associated lockdowns. And so you have some flexibility that you can potentially use some of these ARPA dollars coming in to cover some of your involuntary commitment expenses. Right? So that's an area that they're looking for potential funding use. This may be one of those funding uses. Counties really don't, you're not a primary healthcare provider. And so that really doesn't fit as much with you, but if you have hospital districts as well, or county-run hospitals, these funds can potentially be used for some of those services. Too far away from the laptop. Again, this is related to healthcare. This is more going to apply for those of you that have county-run hospitals or skilled nursing facilities. But some of these dollars can be used. This is a little more narrow, so I'm not going to spend much time on that. When we talk about non-medical, and Kelly's going to talk a little more about non-medical in her comments as well. This is another area that's expressly called out within ARPA that is an allowed use of the dollars, right? It specifically states that funds can be used for food assistance. And I know a lot of you fund senior meal programs, right? And this might be a potential source for funding those senior meal programs that you might have. Some of you in your non-medical indigent policies that you have will provide rental assistance, utility assistance, things of that nature. And ARPA allows you to use these dollars for those purposes, right? And so if you have those programs within your county, you can potentially use these funds for that. I will say that there are other funding programs in place, like that Ada County, I believe you guys received a sizable amount of money for homelessness, right? ERAP, right? And so there are other funding pots when you're talking about housing you might be able to tap into, depending on your situation. But this can be a potential source. It also calls out affordable housing. I know many of you are looking for ways to jumpstart affordable housing programs within your community. This might be a potential resource for that. And then lastly, and this is going to be a little more complicated than what I initially thought as I've been talking with the public health districts. There is broad allowance for these ARPA dollars used for COVID-related services, contract tracing, vaccination clinics, monitoring and tracking of data. Now, on the surface, sounds like that's an easy use of these funds. But where it gets complicated is health districts are getting money from other federal sources to do these things, and you can't double dip. And so, depending on what it looks like, you may or may not be able to use some of these ARPA dollars as we dig into it for public health district-related services. But so again, this is an area where we're going to seek to get a little more guidance for you, because initially this was an area where we thought there would be a lot of flexibility to use the funds, but as more information comes out, it might be a little more difficult on that one. So we'll work to get guidance here. Now, as you have questions on what can you use these funds for, Sarah, raise your hand. So y'all know Sarah. Sarah is going to serve as our point for these policy questions. So email Sarah questions. She'll be compiling those questions, and then we'll work again with an outside contractor to provide some assistance and guidance. Sarah, her email is swestbrook@idcounties.org, swestbrook@idcounties.org. It's on our website. You probably have it in your inbox anyway. But don't hesitate to email questions, Sarah. We're not going to be able to turn around quickly and get you an answer if you want to compile things, and then we'll work to develop some support documents to help you in this. But there's more to come. The other thing that I'll stress, we're not intended to be a full-on ARPA presentation right now, and that's tomorrow. I wouldn't be in a huge rush to spend the money either. You've got plenty of time to use the funds. You've got up until December of 2024 for most uses. If you end up using the funds for a capital project, you have all the way until December of 2026. So there's no reason to just jump headfirst and use the dollars. The other thing that's a little bit in limbo right now, you've probably seen news articles and whatnot about this next transportation funding package, well, infrastructure package. It's not just transportation that the Congress is working on. I think the goal at the end of the day is to have a bipartisan infrastructure bill, both Republicans and Democrats support. Initially, the Biden administration was recommending 2.3 trillion or so in spending on infrastructure. The GOP counter was a little over $500 million. It's a pretty big gap. And as I understand it, they're to about $1.1 trillion right now. There still will be continued discussion. And I know one of the things that the GOP is asking for back in Congress, this isn't in a bill yet, so don't take the thing. But it's part of the reason why you might want to wait until you get into the next budget year before you really start spending these funds. The GOP is asking for whatever infrastructure bill that moves forward for it to include language that would allow you to use these ARPA funds for transportation purposes. You can't do it right now. It's a no-no, so don't try to do it. But we don't know what Congress is going to do, and if they can negotiate this, it's really going to open the door for counties to be able to use these ARPA funds. So just let's watch and see how this plays out over the next couple of months. I'm going to hand the microphone over to Kelly, and she's going to talk a little bit about the future of the program, where things are headed, and then I'll run the mic.
So just, I know we're running short on time, but I kind of just want to go through what we're looking at moving forward. One of the biggest areas in our highest costs is behavioral health. I talked about it a little bit. You can see the increased case loads that we're getting, as well as our increased costs. However, with the implementation of House Bill 316, we should, and the IMG waiver, we should again continue to see the county costs drop. So Seth mentioned with the discussions of House Bill 316, there was questions about who really should be responsible for mental health costs. You have your psych, medical, hospital, but you also have your transport and your DE and your court costs, your court proceedings costs. And the hospitals essentially at this point are responsible for those costs because of this bill. They said, well, why us? Why are we? And when they asked the question, I said, well, why was it us? Why are counties responsible for it? It is a state system, the court system, that is taking their liberties away. And so both of us kind of agree, well, why doesn't the state pay for it? And the state went, well, wait a minute. We don't want to spend any more money. Maybe we should have a bigger discussion. So you may recall that back in July, the governor did an executive order to create the Idaho Behavioral Health Council. They've been meeting. They have a lot of groups to look at various sectors of the behavioral health system, and they've come up with a strategic plan. With that, they have a bunch of recommendations in these certain areas. You can see they're looking at infrastructure, promotion, prevention, engagement, treatment, and recovery. Now, there's a lot of recommendations within each of these categories. We met with the co-chairs of the Behavioral Health Council, Seth and I, with a couple of legislators and some hospital representatives, and they asked us to participate with them and not create a separate working group so that we end up going in different directions. And that is the reason that this council has been put together, because there was this planning council, this behavioral health council. Us as counties, over the last, well, since I've been here, we've discussed behavioral health in a various, different ways. And really, the executive order was trying to circle in the wagons and go in one direction altogether. So we'll be working with that interim group to talk about where do these costs and their responsibility really lie. Especially when, look at the implementation. how are we going to turn around and charge court costs, transportation costs, and then DE costs to the hospital as far as process? Thankfully, we have some time to discuss it. We have the next interim session to clean up the bill as we need to. So as far as the recommendations go, I'm just going to talk about the treatment section. If you're interested, you can go to their website and look at the full document as far as what they're recommending to move forward with as far as changes in these various areas. But within treatment is where I think counties are going to see some changes. The first one, I can be closer, I can't see that. So really, in the discussions that I've had with the legislators and the co-chairs, is really about the process, the civil commitment process as a whole. What should it be? Seth mentioned the 2 DEs. When I was talking to the administrator of the court, she is one of the co-chairs of the council, and she said, I can't tell you one person that I've come across that says, we need 2 DEs. So why do we have 2 DEs? It's a very good possibility that one of those will go away. So we're going to look at this whole process. And you can see definitions, streamlining the DE process. We want to standardize court procedures. My clerks are probably going, oh God, please don't let them do this. Let us streamline these processes. But these are all the things that we're going to look at as a whole. And of course, the costs and where they lie. Another recommendation is to improve the efficiency and effectiveness of the Idaho criminal process related to the determination and restoration of competency to stand trial. As this is a court-related function, I wanted to bring this to your attention so that you can understand that there will be some possibly, again, court procedure changes coming in your future. I recommend that you go to the website, you follow the documents, put in your public input, especially the clerks that are, well, all of you are highly involved, but if you have input on what those processes should be. And the next one is to improve the efficiency and effectiveness in regards to our juveniles. Now, the Department of Juvenile Correction does presentation. I've seen it in various capacities, but mainly in the Criminal Justice Commission, and it appears that they're doing very well in keeping their numbers very low. So this one obviously isn't as long as the others, but it'll be something that we'll want to continue to watch as we have a very close program between the juvenile program and the counties. So I'm not going to go too far into non-medical. I think Seth really covered it. I mean, you have the opportunity to utilize your ARPA dollars in this area. House Bill 316 does not change anything that you're doing in regards to non-medical. So how many of you do non-medical? I'm curious. I'd say pretty much every county has some sort of non-medical. When I worked at Canyon, we did indigent burial, and that's it. Other counties, like Ada County, I believe, do rental and utility as well. No? Yes? So this will not change. So lastly, the medical side. Again, if an individual is eligible, not necessarily afford, but eligible for insurance, that's not just the exchange. The exchange was brought up, but this is also your employer or your spouse, any insurance available to that individual. So if an application comes to the county, you're still going to have to process it. But the applications that you process are the ones received up through March 1. After that, if you receive an application, we don't process it. We still process. It's a denial. The great thing about this bill is you didn't have a resource or the ability to deny an application based on insurance before. You just had to process it out. But now you can. So you get it. They either qualify for Medicaid or they don't. I'm going to give you a couple of screenshots that the clerks may be familiar with. I know the indigent directors are. They're part of the Medicaid determinations that they receive with the applications. So for like this one, this individual applied, or they sent in the combined app, and he failed to provide. Now, this application is going to go to the county because he failed to provide his information to the hospital or to the Department of Health and Welfare to see if he actually qualifies. The county is still going to have to do their due diligence and see whether they qualify for Medicaid. If you receive your verification, send them to the department, or they're denied based on insurance. Here's another portion that some may have or have not seen. On the determination, it'll tell you whether the individual qualifies for the tax credit or not. This individual is not eligible based on the fact that they make too much money. I don't know that I have that screenshot. I might have on the next one. But he is ineligible. So you have that information in your hands when those applications come to the county. You want to really utilize those, be in contact with the department, contact the confined unit, see what they need. If you get those verifications, send them back. This is the same individual, just wanted to show you the rest of the form, what they know about your household. He was obviously over income. I wish I made that much per month. So I'm not going to go into it. I mean, we talked about it through the whole thing. The future of the program, it is still in place. It is not going away. Now, within your counties, you need to determine based on your caseload, and you saw in the trends that the caseloads are going down. If you have staff in your indigent programs, you need to decide how you're going to move forward, whether you're going to move them around or you're not going to keep them. But the program itself is staying in place. You will still need to receive your reimbursements to send within your county and then send to the state. So until the legislature repeals the program, which they have not, the program stays in place. Any questions? Kevin?
You will take him the mic.
Yeah, I'm gonna bring you the mic, Kevin.
He's going to give me a really hard one that I don't know that I'm going to be able to answer because he's good like that.
Okay, well, thank you. And talking to my coworkers across different parts of the state, one question we have, and I have several for you. Can you define eligible for insurance? Is that going to be defined in code so the county's not hanging out there waiting for the courts to handle this?
No, that's a simple answer. I cannot, I mean, define eligible, if they meet the income requirements for Medicaid, which, I mean, you may or may not know what they are, you'll know the Medicaid determination, you can provide that. So they may still be eligible for Medicaid, you'll process it the same. For insurance, it's eligible, not affordable. So there might be expendable income if they can purchase insurance through the exchange, which most everyone can. I wouldn't say that, unless you have zero income, and then who knows, I don't know the ins and outs of the exchange. They're eligible for insurance.
Are you going to include the affordable portion in code?
No, it is then the statement of the legislature that is their policy that you either are going to have insurance or you're going to have Medicaid.
And then does that also eliminate workers' comp, Medicare?
I would say that all your resources still stay in place. You utilize them as you have currently.
And then on the 3/1/22 date, if the person goes in on February 25th, you don't get out till March 15th, are we splitting that application? On 3/1, saying 3/1 on, they could have had insurance, you don't pay for that, but the first part, we do, or how are we operating on that?
I would say yes. The way that it is that March 1, they either have Medicaid or they have insurance. So you would only process up through that. But that is, I think, a gray area that you may want to explore with your process.
Kelly, what I'm getting at is,
Start from the mic.
it's more focused on data service, right? I mean, they go in February 15th, they're still receiving services beyond that March 1st deadline. And that's probably where there's, I guess, more gray than anywhere in this. And that's one that likely will be litigated. Now, to let you know what our hope and intent is, I've already started talking with John Vanderwoude, and what we're hoping the legislature will do is, again, we'll know the position of the Supreme Court probably by the end of this month on the Affordable Care Act. If everything stays in place, I think, the likelihood is pretty high that you're going to see the legislature just repeal Chapter 35. And if it's repealed, then all this goes away. You don't even worry about it. And I think that's the cleanest way to address that. We actually drafted language for Representative Vanderwaal in this last session to do just that. But Fred Wood was unwilling to do that until the Supreme Court decides on the Affordable Care Act.
And then the last one is just basically a comment from all the other directors. If the person does not cooperate with Medicaid to determine if there's a Medicaid eligibility, why not just say that's an automatic denial, rather than forcing everything back to the county for us to do all the investigation and then go back to Medicaid to see if they qualify, or try to figure out, well, they could have bought insurance somewhere and.
Well, as the programs are still in place, I mean, we would have to make that a legislative change. And we had small discussions around that, and I don't think the legislators were ready to change that much of what the department is doing. And they felt that, well, if they have the resources, Medicaid is doing their job. I'm with you. I felt like that something could have been a little stronger in there to make sure that the hospitals, one, because they're the ones that initiate the process with the patient, to make sure that they provide more information. And that two, the Department of Medicaid, or the combined unit, is, working a little harder to make sure that we don't even receive them. I tried for that, we weren't successful. So we're still gonna have to process the applications that come.
So Kelly, there are a few questions here that I'll try to tackle in the chat from our indigent directors who are participating. They're coming in too fast. And so there's a common theme here. It's like, who isn't eligible for insurance, right? And really the only group that we've been able to identify is there are probably some circumstances where undocumented individuals can't buy insurance. Other than that, anybody else in the state can buy insurance. And so, again, you're going to want to work with your PAs as you go through the prosecuting attorneys as you go through the denial process of these applications. But this statute does give you the ability to deny an application for failure to buy insurance.
That is also one of the reasons for the later implementation date. Some of the legislators felt that by cutting them off right now when the bill was signed, or even at January 1, we're not giving the individuals who don't have insurance enough time to go through the next exchange process. But the legislators were like, well, but they had last open enrollment and the enrollment before that. But it was noted that, some individuals may have circumstance changes, and so they're giving them through the next enrollment period.
Two other questions here. One of them we addressed early on, the individual probably missed it. What happens with jail medical? Again, county will continue to have responsibility for jail medical services provided inside of the jail, well, while an individual is in the county's custody. The other question, and I don't know if we have an answer for this one, what about the individual that is underinsured because the policy they bought through their employer doesn't cover much? And that's going to be a
another gray area. I mean, they have insurance. So technically they have insurance. It's a denial. It's not your responsibility to say, well, they could have bought, more coverage. They have insurance. Now, which coverage did you buy? I didn't, buy coverage to cover my broken leg, but now I have a broken leg. I mean, who knows? But they have insurance, so it would be a denial.
And again, this is something that all these questions keep popping up. We've got the summer to work through them, and we've got the first 2 months of the legislative session to run legislation. And I want to clarify something I said. I mentioned that we had worked with Representative Vanderwaal to repeal Chapter 35. The draft wouldn't have repealed everything in Chapter 35. It would have left in place the reimbursement statute so that you continue to seek repayment for those services that have been rendered, and that will continue. When I referenced the repeal, that's the part that requires the counties to meet the first $11,000, and that's the language that needs to be yanked. So, Tammy? Here, I got it.
I can share.
I was just curious, how many people are there out there that are eligible for insurance for Medicaid that currently don't have it, that are gonna land in their laps? What's the percentage?
That don't have Medicaid or insurance. Now, those are the folks you're paying for right now. Now, of those folks you're paying for right now, how many of them are eligible to sign up for Medicaid and for insurance? My guess is just about every one of them walks in that door. And so again, the intent from Representative Wood, and it was his language, the language that limits eligibility. His intent was, nobody has an excuse not to buy insurance or enroll in Medicaid. And so the state and the county shouldn't be putting the medical bill for those individuals. Right? Now, the cleanest way to do that is to just remove the requirement from statute. That's going to be the next step. Okay, Jack?
All right. Hey, Seth, Kelly, Sarah, Tim, I think that's all of the IEC staff. Did I miss anybody here today that's here for this conference? Thank you. We appreciate everything you guys do behind the scenes and at the conference.